a 12-year-old boy who had relapsed acute lymphoblastic leukemia 4 years after the completion of standard risk leukemia treatment. Diagnostic and staging assessment confirmed that he had a combined bone marrow, CNS, and left-sided testicular relapse. He did not have fertility preservation at the commencement of his initial diagnosis. He has a sparse, faintly pigmented pubic hair and the testicular volume of 8 ml. He has erection and wet dreams but had not masturbated before. He became very embarrassed having this conversation with his parents, felt that it was not relevant. The parents also felt that it was not relevant to ask their son about these questions.
Yes, so this is the challenging case of the almost a boy at the level of the puberty. So first, I would like to ask Dr. Joshi about it, like from the oncologist perspective, how can you provide insight on this case?
I think Dr. Bhausa will be a better person because I deal with the solid tumors. So I think
okay,
Bhausa,
sir. Okay.
But whatever I can, if there is a CNS involvement, the prognosis is not going to be very great. That I can say. I think Bhau can further take.
Yeah, sure, sir. So I think coming back to assessment of an individual patient, so we have to determine the prognosis, the required treatment, the chances of infertility with that treatment, and this case aptly highlights that. So depending upon the treatment modality, which are going to use chemotherapy, stem cell transplant, radiation involving brain as well as testes, we have to factor into the person's chance of infertility. So for this person, he is going to require a salvage chemotherapy, and that would be followed by a transplant, which will also require probably total body irradiation. So his chances of infertility are very high unless and until we offer him the preservation. And I think is pivotal, and if it is easily feasible, and looking at his parameters like his counts, his performance status, hopefully we would have some time to preserve the sperms.
Okay, sir. Thank you, sir. So I would again.
The most important thing in taking these sorts of decision is the prognosis. So the most difficult question as an oncologist, what we feel about whenever we discuss the fertility issue at a basic, the question is that how the patient is going to do in long term.
Yes.
So at that point of time, discussing fertility issue in a case where we know that the prognosis is not going to be very, very great, it's very difficult to make a balance between the decision of a continuing chemotherapy or planning some very intense chemotherapy, and in the background then we have to discuss about the fertility also. So that becomes a very, very challenging job as an oncologist. For other cases where prognosis is good, we push them from our side to get all these things. But in a disease where prognosis is not going to be very great.
Sir, I agree with you, sir. Prognosis needs to be, and then only the need of fertility preservation can be discussed. So this is a 12-year-old boy, and he has a pretty long progression-free interval, almost 6 years. And looking at means childhood ALL salvage rate, he still should have a cure rate which should exceed 40-50%. So I still would want, if possible, preservation of sperm, sir.
Yes, sir. Yes, sir. Because this is really challenging with respect to the prognosis and how we deal with this, because it is very distressing situation. Cancer diagnosis itself is a lot of stress, and at that point of time, discussing fertility, that might give a false sense sometimes to the parents that yes, I mean it is a very good prognosis. That also shouldn't happen. So this is very, very challenging in that part. So definitely, I would like to ask Dr. Tibrewala sir about the further options, like in such a situations, how to deal with that, and of course we can discuss in this the surgical extraction options.
As Sangeetha had mentioned, that the category gonadotoxic categories can be for no risk, low risk, intermediate risk, and high risk. No risk is 0, low risk is 0 to 20%, 20 to 80% is intermediate risk, and over 80% is high risk. Now, I think that this child of 12-year-old boy would probably fall into the high risk group. If he falls into the intermediate or the high risk group, he is the person who definitely needs counseling on preservation. We need to take the help of a counselor who is a pediatric counselor, not an counselor who deals with adults, because the counseling will have to be done at a different level, a different age level. So a pediatric counselor would be ideal to help in that case. Now, parents have to be taken into consideration here, because this boy is too young to take decisions on his own, and his parents feel that his son should not be asked these questions. So the parents will also need some counseling to make them realize that this is the quality of life that is going to be affected when the child grows up. Of course, he's at a high risk. What his survival rates are, that will also have to be discussed, right? So that is one thing. So now in this case, there's no question of getting any semen, because he's only 12, and although he's saying he's having wet dreams, which I doubt at 12 years of age, but anyway, the chances of getting sperms from that, from a semen sample, even if he is convinced to produce a sample, will be very, very low. So you can try percutaneous sperm aspiration from the epididymis if the epididymis looks a little distended, which is a very, very simple procedure rather than doing a microtessay and extracting the tissue. And then that tissue, of course, if we find that there are no sperms at all anywhere, then that tissue has to be used for freezing. And testicular tissue freezing is done at many, many centers, even in India. So that is not a problem, and it can be used. But in this case, if no sperms are there at all, then what we are looking at is in vitro maturation of sperms at a later stage, when the technique does develop, because you may get spermatogonia at particular, in certain of the tubules, and the spermatogonia, the sperm, these are known as the premature sperm cells, the spermatogonia at the basal level, and they can be used, and techniques can develop to mature these spermatogonia into sperms when it's available, and it can be used. But at this stage, I doubt we will find sperms in the testes, even with even with microtessay. But that is an option to be kept in mind. And of course, more important is the freezing of the testicular tissue for use at a later stage.
I think some problem with the voice.
This child is also looks like he is, with sparse, faintly pigmented pubic hair. He is not yet a Tanner staging. So if he had not had this cancer problem, we might have stimulated him with some kind of hormones. But because of his cancer, we cannot have that much time on hand. So whatever the best that can be done is testicular tissue freezing for use at a later stage. Thank you.
Okay, sir. Yeah, thank you so much, sir. Yeah.
Hello?
Yeah.
Yeah.
So
Yes,
what are the charges for this? How when we have to counsel the patient, the testicular freezing, how is there any like a yearly charges like a sperm preservation?
Yes.
So if you can brief it, that will be helpful.
I would like to ask Snehal if they are
Yes, sir.
doing testicular tissue freezing. Are you?
So basically now testicular freezing, it is like it is still a experimental technique. So we need a institutional review board for that. We have that, all the facilities. Still we are not currently doing it, because accordingly it has to be we need to take a review from the ethical board, and then definitely, but we can very well do. So costing, as sir was asking, so it depends upon the TISA costing and or the micro TISA. So generally TISA costings would go for up to 40,000 procedure costs, and the micro TISA would be around 80,000 at our settings, and then the freezing costs are there. So for the 1 year, generally it is the 10,000 for a yearly freezing, and we need to renew every year. Maybe now that is also one point we have to discuss, that we have put it about the costings and all, because still these kind of things, it is not involved in any insurances. Even the trusts which are there for the cancer treatments, they are not giving the funds for the fertility preservation. They are giving the funds for the treatments. Of course, the insurance policies, they are covering the complications like iatrogenic complications of the cancer treatment. But of course, yes, that infertility is also one of the iatrogenic complications which has to be covered. It is still not covered, so it's a big debate. So we need to make arrangements, then only it will be, feasible and more accessible to the people. So of course we have all the facilities, but still we are having these challenges. So to take forward these kind of cases.
No, I want to ask you one thing.
Yes,
that in
sir.
India, you said that testicular tissue freezing is not allowed, or it's
No,
allowed?
it is allowed. It is allowed. It is experimental technique, so that it is allowed with the institutional review board committee when you have. So it has to be with that committee, get approval, and accordingly we can go ahead with the cases.
So ICMR has no guidelines on this?
No,
as yet?
ICMR yet has no guidelines on this.
Okay.
Yeah.
Do you know any center in India that is doing in vitro maturation of spermatogonial cells?
No, not in India. There are centers well developed in the US, UK, and of course Canada, because there is a lot of work going on there. They have the Oncofertility consortiums and all, but not here yet. Yes.
Okay.
So basically, still there is a lot of raw area in this field.
Yeah, I don't think you'll get any sperms out of the testicular tissue that you will, extract.
Yeah.
That is my, that's my take on this. At 12 years of age, chances are very, very minimal.
Yes.
And already you're saying that he has only sparse hair, pubic hair, so he's probably not
Yes,
even
in
had
this case,
proper
definitely.
maturity, So that's one thing. Now this is showing the testicular sperm extraction. I think Sangeetha is in a better situation to answer this technique,
Yeah.
or you maybe.
Yeah. So testicular tissue. Yeah.
So this testicular tissue cryopreservation, where usually here in TISA, where we get the biopsied sample, we tease them, and here along with the culture media which had sperm, even we freeze the testicular tissue also, because later, in case if we want to, if we have utilized one vial, and if we later want to see whether we can tease those tissues also to get the sperm and reuse it. So we usually freeze it as two. One as the sperm suspension with the culture media, and one as a testicular tissue. But these are in patients where we find sperm. But if we do not find any sperm, it's no point in freezing the testicular tissue. So here, when the testicular biopsy is done, we get a very small piece of tissue, where all the tissue pieces are teased, minced. We take it and store it in the cryovial, and as I said, it's in two ways. One is a sperm cell suspension, another as a testicular tissue for later use in case if we have to extract or tease them, so that unnecessary repeat of another teaser we can avoid them. And we store them, we subject them with the cryoprotecting solution, and we don't vitrify, we use a rapid freezing technique. And these samples later can be used for either stem cell transplantation, tissue grafting, or tissue culture, which is not, we are not practicing it yet. These are still an experimental procedure.
Yeah, I'd like to add something here, that when they do microscopic evaluation after making a cut, they are able to identify certain areas which look, where the seminiferous tubules look more full,
Yes.
and these are the tubules which can be extracted, cut and removed, so that you can look for sperms in that, rather than going blindly and making multiple punch biopsies and then looking for sperms in all the biopsies. So
Yes.
microKP has some advantage over the others, but there are some people who believe that instead of just making one incision, small incision, and trying to look for the sperms in that, from the tissue from that incision, when I spoke to some doctors who had come from USA, they said that we completely they open up the testes into two halves, like what it looks like in this diagram over here.
Yes.
And then they open it up into two halves, and then they look under the microscope to look at the tubules which look more distended. The tubules which look more distended are the ones where you are more likely to find the sperms. So then they say then we take those tubules and cut it, because the embryologist, Sangeetha will probably agree with this, the embryologist goes mad looking for sperms if you give them lots and lots of tissues to look for. And if the chances of finding sperm in that particular sample is very low. It takes 6 to 8 hours to look for sperms in some of the samples, tissue samples. So if you can directly look under the microscope and decide which area to cut and extract, it may be better. I'm sure Sangeetha would be happier with that.
Yes. Yeah. Yes, sir. Thank you so much, sir. So, sir, I would like to, because,
Can I ask
yes, sir.
one question?
Yes,
So,
sir.
suppose like in a testicular cancer patient, the archidectomy is done at a different initially the sperm analysis was tried and it was found that it was not it was agiospermic. Can this be technique and the patient underwent archidectomy? Can the tissue can be transferred to other place to get it, or it should be done at this micro test to be done at the same place, or it can be transferred to the other place for 2 hours, 3 hours, and then the rest will be done at that place?
Yes. So, basically,
I
sir,
think, that if a patient has got testicular cancer, then this is not a testis from which you want to get sperms out, even if the whole testis has been removed and kept aside. What do you say, Snehal?
yes, sir. Actually, if it's a testicular cancer, it is not ideally from the deceased testes. But if in case the orchidectomy has been done and the other testes, if suppose it is normal morphologically, maybe yes, we can go ahead and have the tissue preservation. And as sir was asking, like it can be, see, ideally it should be at the same center. And I think for the transport, I would like Sangeetha to add some insights for the transport of the tissue. Within how many hours? Like
It should be almost.
Louder, please.
Yeah, sorry.
hours.
Hello.
Yeah.
Sorry, usually we do not transport the tissues, and even if we want to, it should be like it is pre-warmed, and the transport should have the warming facilities to transport to the other center, and the other center should also have the ability to freeze that. So the freezing techniques, everything should be followed under aseptic precautions.
Yeah. So ideally, we would like to do it at the same setting. That's why, sir, ideally it should be a institutional where we have the fertility unit in the multi-speciality hospital. Basically, that is very important. And then the oncology unit at the same building or whatever, same hospital where we have the same facilities. And immediately we can, take forward these kind of, especially ovarian tissue and testicular tissue cryopreservation. That's why we need a multidisciplinary team. So it has to be there at one setting, ideally.
I'd like to ask one question to our oncologists present here today. What are the chances of the other contralateral testes developing cancer at a later stage, if it is left?
Yeah, sir. So by the definition or by the whatever the data we have, it's around 1 to 2% patient may have a chances of developing the condition. It's not very high. If we are giving chemotherapy, suppose for this one testis which has affected, even with the chemotherapy, though there is a theoretically a blood testis barrier, but we have seen that some amount of chemotherapy may pass through this barrier and will kill the tumor cell there also. So patients who have received chemotherapy have undergone archidectomy of one side. The other testis getting testicular cancer in due course of time is around 1%. So mostly it's not that. Those patients who have not undergone chemotherapy still incidence maybe is a little bit more, but after chemotherapy it's around 1 to 2%.
So we can actually get tissue out of the contralateral testes and look for sperms and store them if they are there, right? Or
Yes.
before starting chemotherapy.
Yes, ideally, yeah.
Anyone from Tata want to answer that?
Yeah, so I agree with Dr. Amit, the chance is really low to have it, but for certain, it will vary from disease to disease. For example, testicular lymphoma, the chance of contralateral testicular involvement is very high, and in that case, you will require a prophylactic radiation to be given. So that's for sure infertility for that test is also. So in other tumors might be low, but certain diseases, for example, this kid had a testicular relapse of acute lymphoblastic lymphoma. So situation here is going to be more complicated, and his contralateral test will not be available for that. Sir.
Yes, sure. Yeah. Yes, sir. So, actually, Dr. Tibirwala sir had to log out early. So, I would like to ask sir if any insights on final comments on the strategies on the male preservation, because after this we'll be starting the cases of the female cancers. So, with these two,
Okay.
yeah, yes, sir.
Yeah. So case 3 you're not taking up, right?
Yes, sir. Yeah,
That's what
sir.
you mean. Okay, fine. I'll keep that paper aside.
Yeah.
Okay, now I have made some notes over here. I have spoken to some fertility specialists, Dr. Sonia Malik, who is from Delhi, who's doing a lot of work in Delhi, very well-known gynecologist. So I spoke to her, and she says I get around 3 to 5 cases for fertility preservation in the male, and per month. So that comes to about how much? 14, 15, 20 maybe cases in a year.
Yeah.
And she says they are only doing cryopreservation of sperm, and they are looking into cryopreservation of testicular tissue. They do freeze some of the tissue so that if IVF is required later on, they can look for sperms in the frozen tissue also. Okay, in case that this microtase is being done. But if enough sperms are found from a sperm sample, then they freeze enough samples so that it can be used at a later stage. And she said that it's very, very important that this is a message from her to our group today that is meeting, that we should have some kind of a guideline, and that we should have dedicated centers, oncofertility centers in India,
Yeah.
because otherwise what is happening, every fertility center starts thinking of preserving, tissues for later use, then they will not get enough information, and they will not get enough samples and tissues. So it's better to have dedicated centers which will be doing oncofertility work, and every hospital that is doing treatment for cancer should be made mandatory to have fertility counseling at that hospital. Whether they have a center or not, they should at least have a fertility counseling. She said that at the center, which is this hospital in Delhi, where it has been made mandatory, the Max Center, right, in Delhi, they have made it mandatory for every cancer patient to go for fertility counseling, whether they go for preservation or not, but some kind of counseling they have to undergo before they go for the therapy. That is one message. Second message I have from Dr. Rishikesh Pai from Bombay, who said that, we were discussing that why don't we have guidelines in India, just like they have guidelines abroad in USA and Canada and Europe. So we need to approach ICMR to formulate some guidelines for the Indian population, and that can be made available to all the centers which are treating cancer patients, so that they can know what guidelines are available, what guidelines are there for them to decide which patients have to be referred. Actually, counseling should be done for every patient, but then the counselor and the doctor can decide whether this patient should be referred to a center or not, but guidelines should come from ICMR.
Yes.
Another thing they said is that, when we are preserving the tissues, whether it is, sperms or whether we are preserving embryos, we are finding that 80% of the patients never come back, for use of the frozen samples, whether it's embryo or whether it is sperm. And they are saying a lot of it is because many of them conceive on their own afterwards. So that is another thing that has to be taken into consideration while counseling, that we are freezing the samples for you, but after your therapy, after you wait for 3 years, 4 years, 5 years, whatever is required, whatever is a guideline by the oncologist, then after that, they may conceive on their own. So if they don't get the period, if it is a married couple and their wife doesn't get the period, she should not just wait thinking that, I could not have conceived on my own. So that counseling has to be done at that stage. Now, few other things I just want to mention. Let me read what I have made notes of. That, every center should have vibrators. Then there are some patients who are not able to produce semen samples. I've had one patient like that, and electroejaculation is required. I had 3 patients, but they were infertility patients. They were not cancer patients. But with electroejaculation, all 3 of them have produced children because they had good semen samples. Then another thing is that vitrification techniques have improved very well. The semen preservation techniques and post-thaw samples are very good. So that is one thing to be kept in mind. And attention has to be paid to the to hypothalamo-pituitary gonadal axis, because some of these patients who are receiving some craniospinal irradiation the axis may be affected, and so we need to do their entire evaluation of the pituitary hormones, the testes and inhibin B, to find out if any of them need therapy, which may be hormonal therapy to help them with their fertility potential after the whole therapy of cancer is over. Now, the testes we know has 2 elements, elements in it. One is the spermatogenesis and the other is the endocrine. Endocrine is quite stable, and it's resistant to treatment, with radiotherapy and chemotherapy, so the hormonal damage is much less with cancer therapy, which is being given to the patient. But spermatogenesis, because it has rapidly dividing cells in it, just like cancer cells, they are also very prone to get damaged. So that has to be kept in consideration while giving chemotherapy, that the endocrine levels may be maintained, but the spermatogenic levels may not be maintained. So that kind of consideration has to be given. And childhood cancer studies which have been done have proved that when they have looked at survivors of childhood cancers who have gone into adulthood and who have got married and who then present with infertility, the incidence of infertility in these childhood cancer survivors is as high as 46% as compared to their own siblings who had infertility, and their incidence was only 16%. So childhood cancer survivors have a very high incidence of infertility, and that has to be kept in mind if they come back later on after marriage. And one has to go into the history of cancer treatment in childhood. Another thing which should be discussed with them if they don't want to, if they are considering tissue preservation or they don't want to consider, because they can always go for donor gametes, whether male gametes or female gametes, sperm or ova. Oocyte donation is an alternative that has to be explained to them, that they can have that alternative available if they are not considering cryopreservation. And lastly, adoption is another alternative that should be offered to them later, right in the counseling stage itself, because some of them may not be wanting to spend so much money, on fertility preservation. And you can counsel them that they can save that money, and if they adopt a child later on, that money can be utilized to bring up that adopted child, which is a good thing for society also. So these are the things which I wanted to mention. And I want to congratulate both of you for the beautiful manual that you have brought out on Oncofertility. I was very happy to go through it, and there's a lot of information available. And the reference work that you have done to write that manual, congratulations and hats off to both of you.
Thank you. Thank you so much, sir. And thank you so much for describing very well